Okay.
Good afternoon, respected senior doctors and dear friends. On behalf of Ahmedabad Family Physician Association, I, President Dr. Dhirendra Sanandia, welcome you all on Facebook Live CME webinar on stroke management. Today with me on Zoom meeting, a senior consultant Dr. Mukesh Sharma from Apollo Hospital, and as a moderator, Dr. Pratik Shah, who is a joint secretary of Ahmedabad Family Physician Association. Now I request Dr. Pratik Shah to give brief introduction of our speaker, Dr. Mukesh Sharma. Please, Pratik.
Yes. Thank you, Dr. Dhirendra Sanandia. I, Dr. Pratik Shah, from on behalf of AFPA, want to introduce about Dr. Mukesh Sharma. Dr. Mukesh Sharma is a senior consultant in the Department of Neurology and Neurointervention of Apollo Hospital. Dr. Mukesh Sharma has worked over last 12 years in the field of neurology and over 750 intravenous thrombolysis for stroke, over 250 mechanical thrombectomy for acute stroke, over 200 carotid artery stenting, over 200 aneurysm pulling, over 100 intracranial artery stenting, and over 50 AVM embolization. Or his other areas of interest include treatment of acute stroke and rehabilitation, movement disorder, and Botox clinic, headache clinic. And he is the first neurophysician who trained as interventional neurologist in Gujarat. Dr. Mukesh Sharma has been awarded degree in DM neurology from one of the prime institute of the India, PGIMER Chandigarh. So he has been invited as a guest speaker at various national and international neurology. So I invite Dr. Mukesh Sharma. Please consider your topic. Thank you.
Thanks, Dr. Pratik. First of all, I would like to thank Family Physician Association for giving me this opportunity. I must congratulate you guys on this in difficult time. You are working so hard, carefree in favor of society. I really salute you all as a frontliner COVID warrior. You are definitely looking after COVID patient, but in this, you should not miss other diseases treatment. So that's why we took this topic to discuss with you because it is one of the leading cause of morbidity and mortality. So, like in for last before 20 years, we were not having any treatment actually. Just we were treating complication we usually happen in acute phase of acute stroke. But in the last 25 years, we have the revascularization therapy in form of thrombolysis. And for last 1 decade, we have the intervention which can be offered for the large artery stroke. So we are going to discuss the changing landscape of the stroke treatment in my talk. You all know the stroke is two types. One is the hemorrhagic stroke, one is the ischemic stroke. The hemorrhage most commonly happen because of hypertension, and second leading cause is an aneurysmal bleed. And it is around 15% of all stroke is a hemorrhagic stroke, while the ischemic stroke is around 85 to 90%. And it may happen because of cardioembolization, maybe happen because of artery to artery embolization, may happen because of large or small artery atherosclerosis. It may because of the end artery hyperhylinosis. So there is so many causes behind the stroke, but the treatment is the same in acute phase. So you all know the diagnosis of a stroke is very, very easy. The one thing which is common is the sudden onset neurological deficit. Is almost always 99% is because of stroke. It can be hemorrhagic or ischemic. Okay, the few things may present same way, like a seizure can have the sudden onset, like syncope can have the same presentation, but they presented with the loss of consciousness. Okay, if anybody is having the sudden onset focal neurological deficit in form of hemiplegia, hemiparesis, hemisensory loss, ataxia, sudden vision loss, you are almost certain it's happened because of the stroke. It can be hemorrhage or it can be ischemia. So for that, you usually do the CT scan or MRI to differentiate between it's a hemorrhage or ischemic stroke. So once you do this, actually we have now we are going to discuss the ischemic stroke treatment first. So we have the three kind of the treatment. If patient comes in the IV window period, that is the 4.5 hours, we can offer the IV thrombolysis. If we suspect the patient is having the large artery stroke like ICA, MCA, MC bifurcation, vertebral artery, basilar artery, then we have the second option also, which can be given up to 6 hours in almost all patients, and a selective patient up to 24 hours. So for the intervention for the acute stroke for the large artery, the window period is now 24 hours. Okay. And the third is the medical management, where we cannot offer the revascularization therapy. So the medical management, the diabetes, hypertension, and other comorbid conditions to prevent the aspiration pneumonia, to prevent the urinary tract infection, to prevent the bed sore. So that is the medical management is the part of acute stroke treatment. This slide is showing that there is a meta-analysis which clearly show the opening of the blood vessels is directly correlated with the good outcome in comparison to non-opening of the blood vessels on time. Second, it's really significant reduces the mortality. You can see 14% mortality in comparison to where the revascularization therapy was not offered. So it's a really wonderful treatment which we can offer to acute stroke patients. So now goal of ischemic stroke is to open, this is the closed vessels, this is the MCA, you have opened up the blood vessels, you have to remove the clot. That is the treatment of choice by chemical thrombolysis or by the intervention. What is the funda behind the opening of the blood vessels? I want to show you, I want to explain you. So anywhere in the body, same in the brain also, if artery is blocked, this artery is blocked, leading to two areas. The one area which is showing in the red is the infarction, which is dead tissue, but usually is surrounded by the huge hypoperfused tissue, which we call the penumbra. So this penumbra is going to convert into the infarct tissue on time dependent manner. Okay. So, and this transformation of green to red, like hypoperfusion to dead, depend on the one thing, that is the collaterals. Okay. So if any patient is having the good collaterals, that patient is going to take more time in conversion from hypoperfused to brain dead tissue in comparison to the patient who is not having the collaterals. That's why in a certain patient, we can do the thrombectomy up to 24 hours, because those patients may have very good collaterals. If we open up the artery after 18 hours or 24 hours, that tissue may revive again and start functioning again. So that is the funda behind the opening of the blood vessels even after the 24 hours. So what the time period guidelines for the different treatment? We have IV thrombolysis, which can be given up to 4.5 hours in all ischemic stroke. And we have the two treatment option. One is the TPA and second is the tenecteplase. If patient comes beyond 4.5 hours, we can do the intervention like a thrombectomy up to 6 hours in almost all patients. And if patient comes beyond 6 hours, then we have to do this color imaging, that is called a perfusion scan. So find out how much is the penumbra. Like in this case, this is the dead tissue, that is the umbra, but this is the hypoperfused tissue, which is still not dead. So this is the candidate for the reperfusion therapy for the thrombectomy. Till now, we are doing the thrombectomy in IC occlusion, MC occlusion, MC bifurcation occlusion, or basilar artery occlusion. Sometime, if beyond that involved, but the significant neurological deficit, we try to do in M2, M3 branch also. So patient comes to our hospital, we do just CT scan. Okay, just to rule it out, what? Brain hemorrhage. Okay, in brain hemorrhage patient, we cannot thrombolize. Okay, to rule it out the hemorrhage, and we do the RBS. Why it is important? Sometimes hypoglycemia totally mimic with the ischemic stroke, and you just give the sugar. If patient is having the hypoglycemia, they improved immediately. So before thrombolysis, only two things is important. One is the CT scan, and second is the RBS. And if blood is not there, if hemorrhage is not there, that is the candidate. Sometime some physician, they ask me, the CT scan normal, what to do? Actually, that is the ideal candidate for the thrombolysis. Okay, something is developed on the CT scan, means the infarction is already developed. So what are you going to achieve if you are doing the thrombolysis or doing the intervention? So the perfect normal CT scan with the clear-cut clinical neurological deficit in acute window period is a good candidate for the thrombolysis as well as for the intervention. Okay, but he should fit in the inclusion and exclusion criteria, which we are going to discuss in a further talk. So the TPA which we give in a 0.9 milligram per kg over the period of 1 hour, and tenecteplase you can give 0.2 milligram, just a single bolus dose. Here again, time is very, very important. Okay, if you are thrombolizing the patient within a 90 minute, you are saying one paralysis if you are thrombolizing 4 or 5 patients. If you are thrombolizing between 90 minutes to 3 hours, you have to thrombolize 9 patients to give one patient complete benefit. And if you are thrombolizing beyond that 3 hours up to 4.5 hours, you have to thrombolize 14 patients. So time is very, very important. Time is brain. Okay, that's why I want to say you should send the patient where the CT scan is available, where the neurophysician is available, so patient can be benefited in a better way. And if you compare from the thrombolysis which you are doing for the heart, this treatment is far, far, far better. Okay, so if you are thrombolizing 6 patients, you save one complete deficit in a brain thrombolysis, in stroke thrombolysis, while if you want to benefit your cardiac patient, you have to thrombolize 33 patients, then you save one life. So if you compare cardiac thrombolysis in MI and thrombolysis in a stroke, this treatment is far better in the acute stroke, but unfortunately is not happening in last 24 hours, 25 years now. Only few percent of the patient getting thrombolysis on time. So we have the drugs for last 24 hours, but only 8% worldwide getting this treatment because of the narrow window period. And most of the physicians, they have the fear of bleed. And the third thing is that it's not working if the large artery occlusion, if the thrombus size is bigger than half centimeter. Okay, so in the first one, this kind of the clot, very small clot, probably dissolve with the IV thrombolysis, but this big clot is the chances of dissolving with the thrombolytic therapy is less. But we should offer in each and every patient who are coming in the IV window period. And you know that big artery occlusion related with the clear-cut high mortality rate, like ICA 53% mortality, MCA 27% mortality, and basilar almost 90%. So if we can intervene on time, we can save this mortality, not mortality, morbidity also. And by intervention, and to support my this sentence, 5 trials back to back published in 2015, they clearly shown the intervention is far better than non-offering the treatment or just offering the IV thrombolysis in the large artery occlusion. So this is my one of the case. This artery is blocked from here, sorry. MCA, and we have started doing the thrombectomy and opened up and this is the clot. We removed. So what is the guidelines to do the intervention? If patient coming with the acute stroke within 6 hours, having NHS score. NHS score is the severity of acute stroke measure. If it is more than 6, it's range from 1 to 43. If aspect is more than 6, aspect score we do on just plain CT scan. And if it is 10, it's completely normal CT scan. It is 1, it's a severely damaged brain CT scan. So if it is more than 6 aspect, if we can do the groin puncture within 6 hours, this is the candidate for the intervention. So how we are doing, I'm showing the real case. This was done in 2017. I got the phone call from the Naroda physician around 3:40, and patient reached in the next half hour, 30 minutes to our hospital. 75-year-old female, non-case of diabetes and hypertension for 5 years, and left side hemiplegia for 90 minutes. So as soon as stroke patient reach on our emergency, we generate the code white. So what is the code white? It's give information. It goes message immediately to the concerned team, like neurologists, concerned nurses, radiologists, emergency physician, and third is a time keeper who is taking the time how the things is going on. Okay, so he reached in 4:10, and we have done the CT scan in next 15 minutes. Okay, so suppose there is a patient in the CT scan, is going to take time. They remove the patient if acute stroke is there in the Apollo emergency. If MRI patient is there and going to take more time, they remove the patient first, they do the stroke MRI first if patient is coming in the window period. So in the next 15 minutes, CT scan was done. This is the way we do, like we monitor each and every, and this is our target. Like we want to do the thrombolysis in a less than 60 minutes. We want to do the CT scan in a less than 25 minutes. That is our goal in each and every patient comes to our emergency. In the same way we did in 15 minutes in this case, we started the IV thrombolysis, prepared patient as well as the cath lab for the acute stroke. And this is the first angiogram. You can see the blockage over here. I'm opening the blood vessels by intervention. Open up, it took me 15 minutes from groin puncture to open up the blood vessels. So everything was done within 1 hour. And this is the next day CT scan. There is a hardly small infarct is developed on CT scan on the next day CT scan. And this is the patient. And immediately after the procedure, patient improved. Okay. So this is the way we are doing treating all acute stroke cases. Sometime we are not offering the IV thrombolysis, particularly patient is having the contraindication for this. Like this case, underwent surgery, actually CABG 1 month ago, and he was on aspirin as well as dabigatran for the atrial fibrillation. He reached in our hospital by 110 minutes, 110 minutes, and having the NHS score 20. This is the first CT scan, which is aspect 10, completely normal CT scan. So here the IV thrombolysis is contraindication because the recently surgery was done. That was the relative contraindication. The second is the patient was on the dabigatran. It's an anticoagulation. Yeah, you can thrombolyze this patient by after giving the antidote. Okay, dabigatran, we have the antidote, that is idrasuzumab, coming in the name of Prexbine. So you just give 5 gram Prexbine and you can thrombolyze if you are not having the facility for the intervention. But we have. So we shifted this patient, and before starting, we hardly take the video of patient before doing the procedure. He is totally new and having the complete hemiplegia. Right side not moving, left side hand is moving. You can see the hand. And right side complete hemiplegia with global aphasia. So we shifted because the contraindication for the IV thrombolysis. This is the left MC occlusion from here. this is the device that is called a retriever stent, and this is the aspiration catheter. We used both together and remove the clot in 2 passes, 20 minutes procedure time, and see just immediately after the procedure. This
नाम
is a
बोलो,
cath lab table
नाम
only.
क्या है? जीप दिखाओ जीप. चलो
We
हाथ
was
ऊपर
not
करो.
started speaking on
हाथ ऊपर
table.
करो पूरा.
We started moving the right hand
करो
completely
ऊपर.
immediately after the procedure.
ये हाथ ऊपर करो.
Can you see?
पूरा करो. Yes.
So this kind of the
Good.
result we can get if
Very
we can
loud,
treat the patient on time. And he started
कैसा
speaking
अभी?
also perfectly normal,
क्या हुआ था तुम्हें?
like a patient had a TI. Okay,
अभी
he
सुबह आया
started
था.
speaking also.
सुबह.
So one is the contraindication where even patient comes in the window period, we can take directly for the intervention. Second, again as a contraindication, patient was on the acetron on Dr. Ramprakash Kothari clinic. She developed the stroke. Okay, and he immediately called me because in front of me she had a stroke, and he sent me immediately. Within 30 minutes, he reached in our hospital. This is dense MC sign. That is the early ischemic stroke sign on CT scan. The rest of CT scan was perfectly all normal. In the last INR which was done 2 months ago, it was 1.7. Again, on acetone and anticoagulation, you can thrombolize the patient, but INR should be less than 1.7. So we sent for the INR. In a 10 minute, we got the report also, and which was 2.4. So beyond 1.7, you cannot thrombolize. Second, if the patient is on heparin or liver disease or some other anticoagulation, APTT should be done, and it should be less than 40. Then you can thrombolize. If platelet is less than 1 lakh, you cannot thrombolize. It should be more than 1 lakh. So these are the few contraindications where you cannot thrombolize the patient. Again, the first case which I have shown you, and opened up. Next day CT scan, perfectly normal. Patient discharged on day 3rd. So this kind of the treatment we can get if we can do the intervention on time. So if this is the patient who came after the window period, in this situation who is coming after the 4.5 hours, we want to do the MRI. Why we are doing the CT scan patient who's coming in the window period? Because in those situations, we don't want to waste a single minute. Okay, so but after this window period of IV thrombolysis, we want to know how big is the infarction. Should we offer the intervention or not? Okay, like in this case, this was a very small infarction in comparison to the NHS score, which was quite high. Okay, 16. Both are not correlating with each other. That is called radiological clinical mismatch. So again, it's an ideal candidate, means she is having the big penumbra surrounding this very tiny infarction. So we again shift the patient to the cath lab. This thrombus in the upper division or superior division of MCA, we have opened up. This was the clot which we have removed. This is the post-procedure CT scan. You can see there is a tiny hemorrhage, not tiny, but it's a small hemorrhage, but it was not clinically correlated with the patient. Patient improved in the next 5 days. And this is the first visit after the discharge. Again, perfectly normal, no neurological deficit, even though patient developed hemorrhage after the stroke. So this is the flow chart we clearly follow that is there in our emergency, how acute stroke coming to the hospital, and we follow in each and every. I have no need to instruct my physician, emergency physician, what to do in what patient. Sometimes patient may come with a large ICU occlusion in the neck also, okay, and like this patient came with a complete ICU occlusion, okay. Sometimes patient having the ICU occlusion, but they are asymptomatic also because of the cross flow from the opposite side, but patient was symptomatic, having the right side hemiplasia and complete aphasia. How the CCA and ICA look like on DSA? You can see that this is the CCA, This is the ICA, which is leaking over here. There is no circulation in the brain. We did the cross to check the cross circulation also, and fortunately she was having the cross circulation, but there was a one more block distally. That is the MCA. That is called MCA. But fortunate part again in this patient, she was having the good collaterals. You can see that suggests patient is having hypoperfusion, but the tissue is still not dead. So what we did, we open up the blood vessels from the neck first. Okay, you can see this is a complete log. I'm opening the blood vessels, ICA, opened up, put the stent, and open up the MCA. Result is the same. This is the post intervention CT scan. What you see is a white over here is actually not a hemorrhage, is the extravasation of contrast which usually seen after the intervention. And next day, after 2 days, CT scan which is not showing any contrast there, except very small infarction over here. And this is she is principal in the some school. So presented with a complete aphasia and right side hemiplegia. You know what is going to be future in this lady. She is speaking before discharge.
कि बोल नहीं पा रहे थे आप और राइट साइड का चल नहीं पा रहा था हाथ पे, हैं? आप आए तब बिल्कुल नहीं चल पा रहा था. हाथ ऊपर करो, दायां हाथ, दायां हाथ, दायां हाथ.
Okay, so this kind of the result we can get. Sometime patient may not have the neurological deficit in form of the hemiplegia, hemisensory loss, or hemiataxia, but they can have the speech disturbance. It's very commonly seen like in the CCU, patient develop the confusional state. Okay, and cardiologists they think it's because of ICU psychosis or CCU psychosis. And actually patient is having the sensory aphasia and having the jargon speech. Okay, whatever he or she is speaking, we are not understanding. So that is called the jargon speech. This boy, he is a young guy working in the diamond industry. At the workplace, he developed some sudden abnormal behavior and a speech. Fortunately, he is seen by a Sailesh Darji. And he recognized patient is having the sensory aphasia. He did him MRI immediately. Okay, and you can see this is the right side ICA, but left side ICA is leaking in the MRI. Hardly very tiny diffusion restriction stroke is there. So he immediately called me, I'm shifting this patient. So when I did the angiogram, you can see that the ICA, severe stenosis over here, and you can see the hazy structure here, that like a cloud. It is actually a clot. So it's a clot floating in the blood vessels. So we cannot do anything, because if you do something over here, it is going to go further. It may block the distal artery. So first we did the intra-arterial thrombolysis, dissolve that clot, and once it dissolved, we did the angioplasty, then placed the stent. Now you compare after the placement of the stent. You hardly see any stent over here. It's perfectly opened up nicely. And he was a young guy without speech or with the jargon speech. You can imagine what is going to be future. This is the next day CT scan. This is the guy after
27 मार्च, फरवरी,
giving completely normal.
आया था तुम्हारी को क्या तकलीफ थी? गुजराती बोलो कोई बात नहीं.
ગુજરાતીમાં અહીં આવ્યો તો ચક્કર આવ્યો ને પછી બોલતો નતો ને એવું થયું.
Okay.
He was not able to speak out.
કેટલા દિવસ રાખ?
Okay. Thrombus load is directly related with the poor outcome. Again, young guy, complete ICU occlusion. We did the thrombectomy from open up from here to up. You will be surprised to see the thrombus load in this patient. Total basket full of the thrombus. Okay. Unfortunately, we have to do the craniotomy in this guy immediately after the procedure because he developed the hyperperfusion syndrome. But he did well even after the craniotomy, and he's doing well. Now he's totally independent. So if patient comes beyond 6 hours, what to do? So we are doing this color imaging that is called perfusion imaging. Okay. This perfusion imaging will show us how much is the penumbra. Like first image, it's related with the hypoperfusion tissue, and this blue dot related with the infarction size. Okay, so this much is the dead tissue is there in this patient, but having significant high hypoperfusion tissue. So this is the ideal case. This lady came from the Unja, and she was having the complete ICU occlusion, terminal ICU occlusion. You open up these blood vessels and you can see this lady having improved completely in a motor power. Still she is having the motor aphasia, but again walking, doing all routine activity without any support with the big ICU stroke is a significant good outcome. Another patient who came after 16 hours. Actually, this patient I did thrombolysis in 2011. He recovered very well. He was on the double antiplatelet, and they lost follow-up because of financial reason. And last year he came in my OPD after 16-hour acute onset, just lying on wheelchair, not speaking anything, having this time on the left side hemiplegia. So I was thinking probably this patient is having the big right side infarction and he is not going to afford my treatment, better to shift him, but better to do the CT scan first. When I did the CT scan, it surprised me. What you see on CT scan is the old infarction that is on the right side, where he presented with the left side hemiplegia in 2011. But nothing is there on the right side of the brain, which is related with the left side hemiplegia. So it surprised me after the 16 hour patient is not having anything on the CT scan. So we did the perfusion scan in this guy. So this all green area is a hypoperfused tissue. Even after the 16 hours, I shifted this patient to the cath lab. This is the ICA, no vessels in the brain. There is a slow flow, collateral retrograde flow from the ophthalmic, from eye artery to again reforming the ICA. So this much is the block. So we place a stent over here. You can see my wire. Okay, and this is the net like structure. This is the stent, and artery is opened up. This is the next day CT scan. And patient who came with on wheelchair on the first visit, follow up. He's walking, having left side hemiplegia a little bit. Same kind of result we can get in the posterior circulation also. This guy present with the sudden onset, complete loss of consciousness. He came in coma state to our hospital, and this is the MRI. Very early changes on the thalamus, upper brainstem, but the rest of the brainstem was okay. Small infarction on the right side of the cerebellum. So this is the angiogram. This is top of basilar occlusion over here. This video is showing how we are removing the clot. You can see that my catheter is coming out. This was the clot we have removed with the first pass and second pass. As soon as I open up the basilar top, patient become conscious on table. And after 2 days, with a mild ataxia, he was discharged.
दूसरा हाथ ऊपर करो, देख के दिखा.
So definitely intervention is having good treatment modalities particularly in the large artery stroke. I'm leaving because of the time concern. So many cases. Now coming to the sometime patient come to neuropathy with minor stroke or TIA. TIA means patient recover within 1 hour. It's not a 24 hours now. 1 hour, there is nothing on MRI. Like this lady who came with the left side hemiplegia, which improved in the 30 minutes. So this is called TIA. When we investigated, actually just doing the CT scan or MRI plain, you are just differentiating between the ischemic stroke or hemorrhagic stroke. You are not able to reach the etiology behind the stroke. So you have to screen, start from the echo, okay, then ECG and sometimes Holter also to find out the cause. Then imaging of the neck vessels, either Doppler or MR angiography of neck vessel as well as the brain vessels. If you are doing these tests, you will get the etiology in around 65 to 75% of the cases. Okay, like in this case, when we got the small infection, some small infection on the right MCA. There was bilateral IC stenosis on carotid Doppler as well as an MR angiography. This was the infarction. So we planned this case for the carotid stenting. You can see severe stenosis over on the right ICA and left ICA again moderate to severe stenosis. So right was symptomatic. So we placed the stent. Okay. I'm doing the angioplasty, balloon angioplasty over here. Then placing the stent. When we are placing the stent, we place the filter first. So whenever we are doing work over here, some debris may go up and block the brain arteries. Okay. So whatever debris go, it will be captured by the filter. Okay. Once we place the stent, we remove this filter. So you can see, you compare this artery and this artery now. So the patient who is having the extracranial or intracranial stenosis, this stenting is one of the option. For the intracranial artery stenosis, we are not offering in the first episode, but patient on double antiplatelet with good sugar, with good blood pressure management, still having the recurrent minor stroke or TIA, we offer the stenting. Like in this case basilar stenosis over here, and we have placed the stent. And she was having the recurrent VBI symptoms. Another diabetic or hypertensive patient, fatty lady, was having the recurrent TIA on double antiplatelet. See the size of MCA. And after the placement of the stent. So definitely non-offering particularly left MCA, and this patient developed complete MCA occlusion. You know the patient is going to have the complete right side hemiplegia and a speech disturbance. So this is about the treatment of ischemic stroke. Now coming to the hemorrhagic part, hypertensive bleed is the most common cause of hypertensive bleed. Most of the time, if the bleed size is small, you just control the blood pressure. That's all. No need to give the mannitol, anti-epileptic drugs. Nothing is required. If size of bleed is small, just control the blood pressure less than 150. Try to keep the blood pressure 120. That is our main goal after the hypertensive bleed. If patient is having the large bleed, okay, these patient may need a mannitol or the osmotic therapy, or may need a craniotomy to save the life. But hypertensive bleed treatment is a management of the blood pressure. Second common cause of intracranial bleed is the aneurysm. Okay, a few years ago, most of the surgeon used to do the clipping, and for the clipping, you have to open up the brain completely, and then you do the place the clip on the neck of aneurysm. But now, in last few years, we have the coiling option, where we no need to open up the brain. You just place your catheter in this is the blood vessel, so this is the aneurysm. You just place your catheter inside the aneurysm sac, fill up it completely with the coils. Once it is totally filled with the coils, blood will not go inside, and this aneurysm unlikely to rupture. So it's a very simple procedure. You can do immediately after the rupture. Even you can do this procedure without rupture also, if indicated. So it's a case. This is called AFPA aneurysm. I place my microcatheter, then placing the coil, and this is after placement of few coils. Totally obliterated from the normal circulation. Big aneurysm, again, two aneurysm. One, this is a PCOM aneurysm and a periophthalmic aneurysm, and placement of after the coils. So thank you. We are having this kind of the treatment for acute stroke now, like the Cardinal is having for the MI. I think the ischemic stroke is going in the same way, like MI treatment. Thank you so much. This is another patient.
अपना नाम बताओ, जीभ दिखाओ, जीभ दिखाओ. Good.
You can see facial deviation.
हाथ ऊपर करो.
Right side hemiplegia before.
दायां हाथ ऊपर करो, बायां हाथ.
And this
करो, हाथ ऊपर
is
करो.
first visit.
अबे ठीक है. कहाँ रहते हो? पहले क्या काम करते थे? पैर ऊपर करो. अभी रिटायर हो ना? किसमें काम करते हो? हाथ ऊपर करो. दोनों ऐसे ऐसे करो. चल के दिखाओ.
Thank you.
Thank you, Dr. Mukesh Sharma, for very informative presentation on stroke management. Now we have question answer session. Dr. Pratik, you have any question?
Yes, I only one simple question, Dr. Mukesh Sharma.
Yes, please.
What about the nutrition? Hello,
Pardon?
અવાજ આવે છે?
Yes, sir. Yes.
Hello.
Yes, Dr.
What about nutrition? What about nutrition in the after management of ischemic stroke?
Yeah. So this is about the intervention part, like but nutrition is very, very important aspect in the acute. All the stroke patient who are candidate for the intervention, who are candidate for the IV thrombolysis, almost all patients who are going in the stroke unit need a intervention program, a nutritional program. So we assess the patient. If patient is not able to swallow, we place the rice tube in almost all patients, and the rice tube is going to prevent from the aspiration as well as give the nutrition also. And immediately all our dietitian, they calculate the total calorie and advise nutrition accordingly.
Yes, sir. One question is, what can do to reduce risk of stroke? What can do to reduce risk of stroke?
Yeah, so we have the two type of risk factor. One is a non-modifiable risk factor, okay, and one is we have the modifiable risk factor. So we can't do if for the non-modifiable risk factor, like we are male, we have more chances. Like age, we are definitely over the time we are getting older and older. Like we are black, definitely we cannot change. Past history of stroke and MRI, our past we cannot change. So these are the few risk factors which we cannot, okay. But there are certain risk factors which can be really change future stroke. And top is the hypertension, okay. If you are maintaining the hypertension is a proper way and normalizing the blood pressure, you reduce the stroke chances 4 times. Same way the diabetes, okay, so the second leading cause of stroke. If you maintain this in the normal glycemic range, sugar, you reduces around 2 times than those who are not having so good sugar control. So these are the two factors. That's, again, the third is the cholesterol control. Then the hyperhomocystinemia also is one of the cause in India, particularly in acute stroke, particularly in young patients. Then your physical activity, daily walking, and leaving your bad habits, particularly smoking. These are the few things by managing. Definitely, you can reduce stroke in your patients. Yeah.
Is there any role of immunity in stroke management?
No, there is no role of immunity in this.
There is no role of
Yeah.
immunity.
Yeah, there is a role of immunity, because there's a fifth cause is the stroke because of determined causes like vasculitis. Okay, the collagenal vascular disease patient, they can have the stroke. So immunity or autoimmune disease comes, but they hardly present with a stroke. Maybe sometimes the CNS vasculitis. In those situations, not routine immunity, but you have to suppress the immunity in those situations. Yeah.
What does the stroke do to the progression of pre-existing dementia?
Yeah. Stroke is the second leading cause of dementia, okay, after the Alzheimer disease. Okay. And we have one diagnosis that is called the vascular dementia. Okay. And vascular dementia has certain types. Some patients have the progressive, like small vessel ischemic lesion in the white matter. They present with a progressive memory loss. Okay. Some patients have the recurrent infarction. That is called multi-infarct state. Okay. So they can present with dementia also. So definitely stroke is one of the, and sometimes a patient can have the Alzheimer also. Together they have the stroke also. So definitely if Alzheimer and stroke both together, we have to treat both also.
One last question is there a radical approach to counteract the free radical in acute stroke management, in acute stroke therapy?
I didn't get you. What do you want to say?
Is there a radical approach to counteract free radical in acute stroke therapy?
Okay, free radical means you want to say that
I think the reactive oxygen species.
no, there is no role.
There is no role.
No.
Mr. Pratik, Dr. Pratik, you have any question?
No, almost clarified.
Yes, sir. Though it's very good and simplest presentation on stroke
I
management.
want to just convey one message.
Yes, sir.
Like in the Western world, they have primary stroke center. They have the comprehensive stroke center. They have the stroke ready hospital. So there is a chain. There is a system where the patient get the stroke. They immediately refer to. Unfortunately we are lacking in India. But it's my surprise. There is more than 100 CT scan available in Ahmedabad. Okay.
Yes, sir. Yes, sir.
So a patient who is coming to you on time, I think call your radiologist, do the CT scan as fast as you can do, so you can offer the IV thrombolysis in these patients. Okay, that is actually we are lacking. I think with the time your confidence will grow, like you are doing the IV thrombolysis for the MI patient. I think you guys also will start also thrombolizing in a brain also. The reason is probably because you are having the lack of confidence. That's all, nothing else.
Nothing.
You are more confident in thrombolizing MI patient, but definitely you are lacking this in a stroke. So your involvement is very, very important. Without involvement of family physician or physician, we cannot achieve good success rate in a stroke management. And your involvement and physician involvement is the key. Okay.
Yes,
if we consider overall India, I don't think the PAM is happening in most of the patient, because all the physicians, they are treating properly all MI patient. That's the reason we were able to reduce the mortality because of MI. Same thing we want in acute stroke also. Thank you so much.
No, yes, sir. One question on Facebook from Dr. Viral Khamar. How long statin and anticoagulant continue after intervention for ischemic stroke?
Okay, the number one, anticoagulation is not indicated in all stroke. Number one, heparin is contraindicated in stroke, ischemic stroke, except if it is a cardioembolic stroke. If you are having cardioembolic stroke, you can give anticoagulation. Second indication, if there is a plaque in the large vessel and there is a thrombus on plaque, then only you can give the anticoagulation. Otherwise, there is no role of anticoagulation. I have seen so many patients treated with the IV infusion with the heparin. I have seen more bleed with the heparin than the TPA, thrombolytic agent. So stop using the heparin except in the cardioembolic stroke or patient is having atrial fibrillation. The treatment as a prophylaxis is that antiplatelet, okay? You can use the double antiplatelet for 3 months, and after 3 months, because the 3 months where the most of the patient with a minor stroke or TI have the chances of recurrence. As the time passes, this recurrence rate goes significantly down. So after 3 months, you can turn to the single antiplatelet, and the single antiplatelet has to be given for lifelong.
So we conclude the session, question answer session here. Thank you, Dr. Mukesh Sharma and Dr. Pratik Shah, for spending our valuable time for us.
Thank you.
And thanks to Apollo team for arranging the today live Facebook webinar for Ahmedabad Family Physician Association. And thank you all the AFP and GSP FPF members who watching us on live Facebook page of GSFPF. And at last, thanks to our web organizer, Mr. Rahil. Jai Hind, Jai FPA. Thank you all.
Jai Hind. Thank you,
Jai
Dr.
Hind.
Thank you.
Dr. Pratik.
Jai